We are live now. So Manasvi, we can start with this.
All right. Hello, namaste. Welcome to ForOptom Optometry Updates Expert Line Panel Discussion. Today we have esteemed optometrists working on binocular vision from 4 countries to discuss about the approach on binocular vision assessment and vision therapy on various parts of the world. My name is Manashvi Karki and I am moderating the discussion today. So let's begin by welcoming our panelists here. First of all, I would like to start with Dr. Marc Taub from United States of uh, Dr. Marc Taub is an associate professor and director of vision therapy and rehabilitation services at the Southern College of Optometry. He is the editor-in-chief of the scientific journal Optometry and Visual Performance, and he also teaches vision therapy and is an active clinical researcher and the supervisor of the Pediatric and Vision Therapy residency. Thank you for joining us today, Dr. Marc. Yes, sir. Would you just say hello to our audience?
Hello, everybody. Good morning from Memphis, Tennessee, in the U.S. Hope everybody is well and staying safe.
Thank you so much, Dr. Marc. Next up, I'd like to introduce Dr. Aditya Goyal from India. Dr. Aditya Goyal completed a master's in clinical optometry from Pennsylvania College of Optometry, Salus University, and has been practicing optometry since 1991. He is the principal of Shankara College of Optometry and is credited for establishing colleges of optometry in Chennai, Bangalore, Ludhiana, along with Shankara Eye Care Group of Hospitals. He also serves as president on the board of ASCO India. Dr. Goyal is a PhD holder and also a fellow of FCOVD. Currently, he practices binocular vision, vision therapy, and rehabilitation in Vision Aid Clinic, Chennai. Dr. Goyal, thank you so much for joining us today.
You're most welcome, Manashvi. Thank you very much. And hello, everyone. I'd just like to add something about Marc. Marc was my mentor for COVD in vision therapy. Yeah.
Thank you so much, Dr. Goyal. Next up, we welcome Dr. Celine Zhang from Sydney, Australia. Dr. Celine Zhang graduated from the University of New South Wales in 2017 and has completed the specialist certificate in the management of pediatric patients in optometry from the University of Melbourne and is now pursuing further studies in behavioral optometry with the Optometric Extension Program Foundation. Thank you so much for joining us here today, Dr. Celine.
Thank you for the introduction, Manashvi. Nice to meet everyone.
Similarly, next up, we have Dr. Ajit Thakur from Nepal. Dr. Ajit Thakur completed his MSc in optometry from Chitkara University, Punjab, and has a vast working experience regarding ocular health and binocular vision in various eye health organizations. He is currently working with Drishti Eye Hospital in Jhapa, where he is actively involved in treatment protocol making for the hospital. Dr. Ajit Thakur, thank you so much for joining us.
Namaste, good afternoon. First of all, I'd like to thank the organizer to putting me in the discussion where my guru is sitting and guru of guru is sitting. And I'll be very pleased to be in part of discussion. And though I'm not an expert in binocular vision, but I'm doing some work in Nepal, so I will try to answer the questions what comes to me according to my experience, and I think we'll have interesting talk. Thank you.
Thank you so much, Dr. Ajit. Similarly, we also have Dr. Sarina Manandhar from Nepal. Dr. Sarina Manandhar completed her BSc from IOM Nepal and Masters from Chitkara University. She is currently working as the head of department binocular vision and vision therapy at Drishti Eye Care System. We welcome you, ma'am, and thank you for joining us.
Thank you so much, Manasvi, for the warm welcome. I'm really glad to be a part of this panel discussion. And hello, everyone.
So without further ado, let's just jump right into the discussion, starting with Dr. Ajit Thakur. Optometry is considered as a budding field in Nepal right now. So how would you describe the status of binocular vision in Nepal? I think we muted here, Dr. Thakur.
Sorry. Hello, I'm audible?
Yes,
Yeah.
sir. Yes, sir.
First of all, before putting my views to the binocular vision status in Nepal, I would like to tell our panelists about some optometrist, the history of optometrist in Nepal. Optometry in Nepal was introduced in 1998 from a single college, that is Institute of Medicine, and from where 6 people only graduates in a year. And it's 2020 now, and there are around 1,000 of optometrists, in Nepal working either in private practice or in their hospital, in any hospital. In Nepal, the NSPC, that is the Nepal Health Professional Council, regulates the activities. That's a government body that regulates the activities of optometrists working here. And they have come up with a very strong code of ethics, and BT is a part of that code of ethics. So we are allowed to practice BT. And if you see the insurance part in the insurance policy of Nepal also supports supports BT. That's a very good thing. What Nepal has. So now coming to the VT part. What is the status of vision therapy and binocular vision clinic in Nepal? First of all, going to that, I will let you know what is the status. What is the status of the problem in Nepal? So when I went through the different papers, I found 5 papers that say that 5 papers, and out of 5, 4 are done in school screening. That is not a hospital-based study. So there is a lack of papers on the statement of the problem. There is no hospital-based study, and there is no community study. And most of the hospital-based study says that the statement, the strabismus is around 10 to 15%, and the amblyopia is around 10 to 12%. And similarly, convergence insufficiency and others accommodative efficiency constitute around 8 to 10% of people. So what I think, this is not the real scenario in Nepal, because they all are school screening studies where the facility of binocular testing is not that much adequate. So first of all, there should be a study to find what is the status of binocular vision problem in Nepal. So for that, we can't do a very extensive study. We can do that is we can make a single guideline for binocular vision assessment. And for that guideline, according to that guideline, all the optometrists working in different parts of the country can examine the patients, and they can diagnose the cases according to a single guideline, and they can send that diagnosis to a central data collection places where, and from there at a certain point of time, we can find the statement of the problem there. So what I think that in Nepal, there are 1,000 optometrists, and no one is practicing binocular vision solely. Means they are working as a comprehensive optometrist, I will tell. So binocular vision and orthoptics is a part of them, and they are spending very less time, and nobody is practicing solely BV. So what I think that if all the optometrists who have basic knowledge, for this BV, from a guideline, they can do the basic test, basic examination, and from there we can set up BV in a stepwise manner. So I want to conclude with the statement that BV in Nepal is at its neonatal stage. Despite a huge opportunities and market and interested optometrists, the field is barely explored at present. Thank you.
Thank you, Dr. Ajit Thakur. Similarly, I'd like to go to Dr. Marc now. Do all optometrists practice binocular vision assessment and vision therapy? Are there any additional requirements or qualifications for a graduate optometrist to practice BV assessment and therapies?
In the US, when you graduate from optometry school, you are a practicing optometrist. To be able to practice and do vision therapy, there is no required extra certification. There is no required extra residency. That is a voluntary thing that people will go through for the process of learning and bettering themselves and making it more obvious for people to find them. Things like the COVD certification or the, for Celine down in Australia, the Australasian College of Behavioral Optometry has a fellowship. There is also in the US and Canada, there are optometric residencies associated with colleges of optometry that will not necessarily give you more information than you would learn through courses like from OEP or ACBO, from courses that we've done through Aditya in India. But what it does is it puts it in a condensed 1-year period, and it does so under mentorship so that you're gaining that knowledge in a much quicker manner than you would out in practice.
Thank you so much, Dr. Marc. Dr. Aditya, how is it in India? Is there anything different to it or anything that you'd like to add specifically as something that's different?
See, in India also, it's something similar like what Marc just mentioned in US. So when we do a graduate program, in that all the students undergo certain amount of binocular vision training and a very basic vision therapy, so they can practice. So there's nothing necessary for a person, nothing extra which is necessary for a person to start vision therapy practice, at least in a very minuscule or nascent stage. And then, like what Marc was mentioning, there are different residencies, there are fellowships, there are international fellowships of COVD, there's fellowship of NORA, there's fellowships of ACBO, BEBO, all those places. So one could upgrade their knowledge and skills with all these fellowships. And there are residencies and specialized fellowships which are available. But then to practice vision therapy as such, there's no specific requirement that you should be XYZ educated and then alone you can start vision therapy.
Thank you so much, sir. Dr. Celine, is there anything different in Australia or anything else you'd like to add here?
It's as with India and the USA, so anyone can practice vision therapy if they wish to. But I would say that most optometrists who do vision therapy on a regular basis usually undergo some further training. And in Australia, we usually go through the Australasian College of Behavioral Optometry, which is what Marc mentioned, or overseas scholarships such as the OEP or CVD courses.
Thank you, Dr. Celine. Similarly, I'm coming to Dr. Sarina now. You're the head of the department in practicing binocular vision right now in Drishti Eye Care. What is your take on this, and what is the scenario any different in Nepal? You might want to unmute the mic, ma'am.
Yes, it's also same over here. We also don't need any extra qualification to practice binocular vision, but yes, we can do the fellowship to further improvise our qualification for that.
Thank you so much, Dr. Sarina. Moving forward, this was from the optometrist point of view. Now coming to the patients, does everyone who visit clinic or hospital get his or her binocular vision or orthoptics assessment done? And what are the defining criteria for a patient for undergoing all these evaluations? I'd like to start with Dr. Aditya Goyal right here.
Sorry, can you repeat the question, please?
Sure, sir. So from the patient's point of view, does everyone who visit the clinic or hospital get his or her binocular vision assessment done? And what are the defining criteria for patient to undergo these evaluations?
On a regular basis, you mean?
Yes, sir.
No, they do not. So on a regular basis, it's just a comprehensive eye examination or just a refractive examination that is done for the patients. But then when I say comprehensive, it does not include the binocular vision assessment in detail. So it's a very basic kind of binocular vision assessment where possibly you do certain amount of Worth-for dot test, a suppression check, and that's about it, nothing more than that.
Usually, how does the referral system work between optometrist and ophthalmologist in the binocular vision cases?
Actually, once again, actually, I think Ajit sir, she is asking that to which patients do you do all the binocular vision tests? Would you like to do? Because how to just pick the cases in hospital? I think she has asked that question. That how do you pick the patients from the hospital setup and do the all examination binocular vision? Who are the candidates to do all the BV examination?
Okay, on a rough
I think
basis, if I have to answer that question, it will be anyone who is complaining of eye strain, headaches. I would like to put them on through a complete binocular vision assessment, or amblyopia. Obviously, I would like to. Strabismus, again, I would like to. So any of those things, or where the history is talking in terms of binocular involvement or even ocular involvement, I would like to put all those patients on a complete binocular vision assessment and then see what happens. If the results are stating anything, any of the binocular changes, then yes, go through them in detail and then provide them therapies if required.
So what about this when child enters to school? Do you prefer to just do all the tests there?
See, in India, as such, it is not a mandated policy that an eye examination is necessary when a child goes to school, or what the American Association of Optometry talks about, different stages at which the child should go through eye examination. So in India, we do not have any such mandated policies. So again, it depends on the parents, but then invariably, whatever screenings are done in India, it is only the visual acuity check. I should not use the word vision check, because this is a forum of behavioral optometrists. So I would not say vision check, but they just do a visual acuity check monocularly. And if that is fine, the child is given a yes. And invariably, no binocular tests are done in whenever we are doing any kind of screenings.
I'd love to agree with Aditya that I do think the history is really the key to knowing whether you need to go down the path of extra testing. If you can use the COVD checklist, you can use the CISS checklist, you can do a modification of that based on your clinical needs. But having something that helps the parent and the child identify that they're having issues, including school issues, including behavioral issues. Asking those questions is really the key to knowing whether you need to go down the path.
I think in my experience as more of a newer graduate, it might be because I'm more of a newer graduate, I do a blanket, everybody gets a full binocular vision test. I feel like unless you do it often enough, you can't really tell when you need to do it and when you don't. So that could also be guided, because our optometry guidelines in Australia state that you have to do the examination for everyone. So maybe it's that too.
So on every kid, you legally you have to do a full binocular vision eval.
I could do some sort of binocular vision evaluation, but I think in my practice, we just do everything. So vergence, accommodation, the whole lot. And I think because I'm still trying to pick what's normal and what's not.
But is that a requirement by the law, or just what you're doing?
That's what I'm doing, but required by law is that you need to have some sort of BV, whether it be a cover test or an NPC.
So do we do that regardless of the patient's complaints or the symptoms, or do we follow the patient's history of the complaints and symptoms and then we follow up with the tests?
I can't speak for every optometrist in Australia, but for myself, I will always at least do a cover test, minimum.
Thank you so much. Please continue.
I would like to add something in this. In our hospital, usually not every patient undergoes the detailed binocular single vision assessment, but we do the basic cover test, NPC and NPA for majority of the patient. And majority of the patient under the age of 18, we do the detailed binocular single vision assessment, especially those who have osteopic symptoms. Since binocular vision disorder is more common in those age group, we do that for that age group. And we have developed criteria, actually, a list of symptoms and list of histories that patient may present with, which is pasted in each optometry and ophthalmology room, so that the ophthalmologist also can select and rule out a patient who needs detailed binocular single vision examination.
Thank you, Dr. Sarina. Similarly, following up from there, what would be the workup plan that you follow for a binocular vision assessment, starting with you?
In binocular vision examination, we assess a number of visual skills, which may be typically overlooked in general eye examination. So initially, I take a detailed relevant history of the patient, mostly osteopic symptom, then any history of injury or concussion, or any history of medication, especially those that may affect the accommodation. Then another most important thing that we must consider is optimum refractive correction, since it affects all the optometric data. And I do cycloplasic refraction in most of the pediatric patients, since pediatric population are capable of huge amount of accommodation. And in case of fluctuating accommodation, mild to moderate hyperopia, any type of tropia, I do copper test for distance and near, and calculate the ACA ratio. Then I measure the NPA as regular PFV, NFV, relative accommodation. I do MEM to determine the dynamic retinoscopy, and I do WFT, finding the fusion and stereopsis by using random stereo test. I assess the ocular motility, fixation, pursuit, and saccade by using Ensugo test. And by collecting all the data, I analyze and diagnose and develop a customized treatment plan for the patient.
Thank you so much, Dr. Sarina. Similarly, anybody would like to add something on anything extra that they do, or anything that she might have missed?
I'd like to say that, you know, the longer that I practice, and I'm coming on 20 years now, the less and less, and this is really for Celine, you will, I promise, you will get better at knowing what's normal and what's not normal. And you will end up doing later on less and less testing as you go. You know, for the newer optometrist, taking all of the data is a great start, because you really do get to understand, you know, what normal looks like, what abnormal looks like. You know, I try to you know, as a teacher, you have to have your students do everything. But you know, personally, I do less and less to diagnose these issues. And part of that may be in that I don't necessarily readjust my therapy based on the specific diagnosis. You know, for example, whether somebody is a CI or a CE, my therapy doesn't change. I generally follow the same program. Whether it's an accommodative versus a vergence, I don't change. You know, where it would obviously alter would be an amblyope or a strabismic, or someone with a processing issue. I'm going to add more therapy, but my core is still going to stay the same. So yeah, that's why I kind of come back to, you know, if I've done 4 or 5 tests and I see that pattern already forming, I don't need to tire the child out after, you know, 15, 20 minutes of testing. I know what I'm going to find, so I'll just kind of stop where I am and suggest therapy or you know, or lenses first if or at the same time if I need to.
I see Dr. Aditya Goyal smiling. So are you relating with this, or would you like to add something on it?
Absolutely. I work more with my gut instinct rather than anything else. So a lot of time I say I can see phoria, which most of you disagree, where when I say that I'm seeing phoria, but then, yeah, that's a gut instinct. And over a period of time, like what Marc says, about 20 years, he's been practicing vision therapy. And similarly over here, I've been doing almost the same amount of time. So you get it over a period of time. This person has this, and like what he says, whether it is convergence excess or insufficiency, you are going to work the same thing. You're not going to change the treatment majorly. It's not that you're going to give some other medication to one person and some medication to the other. You're working the same. Only thing is you want the results, and yeah, work a lot with rather than the testing, the results may mislead you sometime. Go with what your tummy is saying.
So actually, I agree with this, that doing test single person will take a lot of time for an optometrist. And so what are the tests that you prefer to do for a non-strabismic disorders who comes to you? What are the minimum tests you want to do, for the cases?
For me, the NPC is very crucial. Repeating the NPC several times is very telling. I love doing the NRI-PRA. It's a great test that gives you both accommodative and non-accommodative data. The divergence ranges. I'll be honest, I'm not a big ForOptom person. In terms of phorias, I'd rather do a really good cover test. But for divergence ranges, I do like in the ForOptom. But you also have the prism bar. You lose some of the subtlety with the prism bar, but really understanding what the different things on the divergence ranges are telling you is really, really, really important. Besides from that,
what about the facilities, accommodation facilities, and that part, facilities part?
That would almost kind of be in my secondary round. Like if I'm starting to do the testing, because that's about 3 or 4 minutes. If you do, each eye 1 minute, and then both eyes 1 minute, and then kind of changing between them. So that's a good 3 or 4 minutes. But based on those other tests, based on the NRI-PRA, just not necessarily the outcome number, but the responses that you're getting. As you're getting to those higher numbers, is there some subtle? Is it taking longer for that to clear? Will give you an indication of whether the accommodative facility testing is going to sometimes be deficient as well. And I'm lucky I have a lot of technology. I love the Readalizer. I love getting those reading eye movements. But you can do that with either the DEM or the King Divic. And that's actually, I'll break out the King Divic in my primary exam, really before everything else, especially if there's a complaint of reading, issues with reading. It's a 45-second test. It can help give you an understanding of when you need to do more testing.
Just to add to that, I love to believe in my retinoscope quite a bit, because MEM gives me a lot of idea about what the monocular, accommodative, or the binocular status is. It also like the facilities apart, but then like I take an accommodative target, take it closer to the patient, and you see NPA and NPCs practically simultaneously. So when it's blur, you go to NPA, you go a little further down, it's NPC. So they're not two separate tests that we look at. And repeat it a few times, you know what is happening. And yeah, NRI-PRA, obviously you're getting with your refraction. So Nothing very major you require, but then it's an understanding of the test and analysis of the results that are more important rather than performance of the test and jotting them down separately.
And
Sir,
I will
as you
say,
told,
yeah, sorry. Go,
sir,
Ajit.
as you told about, sorry, sir, as you told about the retinoscopy, it's very debatable. Some says that you should do cycloplegic refraction. In what cases you just say that we should do cycloplegic reflection, and these are the cases you can do. You have to do cycloplegic reflection. As you know, it's a troublesome thing.
I personally do not like to cycloplegize my patients on a regular basis. I want to see them. So it's something like paralyzing a person and trying to assess him. I don't like to do that. I like to see his accommodative functions, the vergence in reality rather than cycloplegizing him. So optometry has great tests wherein you could do so much with the non-cycloplegic tests. So I personally don't think it's necessary to cycloplegize everybody. But then, yes, if it is necessary, yes, we do have the therapeutic rights to do that. But then those are the tests which were created when diagnostic drugs were not allowed. So the great people who have worked on those tests, I think we should make full use of those tests.
I agree on that note as well. So I feel like even with cycloplegia, it's only in certain few cases where I do get more information than what I've already gotten with my retinoscope or with my other testing.
I would love to agree with Aditya on the retinoscopy component. I'm lucky I get to work with Dr. Glenn Steele, and he's pioneered the concept of the just look retinoscopy, where essentially he's just taking either an accommodative or a non-accommodative target and simply just looking at both eyes and looking at the pupil reflexes. You know, in theory, if we're supposed to be at a specific plane looking at something, well, by all means, we should be locked in at that plane. There shouldn't be any pupil hippus. There shouldn't be any changes in color. This is even before putting in any lenses to check a reaction to them. And just by simply, and this is with a spot scope, looking at both pupils while at a set near target, and what is the child doing? What are the pupils doing? What is the reflex color doing when they're supposed to be doing that? And then insert some plus 50s or some plus 1s or some minus 1s. What happens? Does that reflex all of a sudden calm down? Does it get to be a little bit brighter? Is there a relaxing of that pupil hippus? And that could be an indication of, you know, am I going to need therapy? Am I going to need some plus lenses to kind of stabilize the accommodative system? It tells us so much by simply looking at the response to a near target, either through just look, MEM, book or Bell retinoscopy, stress point retinoscopy. There are so many great ways to do it.
Thank you, sir. Thank you so much. Similarly, now moving on to the next question, we have faced a lot of troubles in regard to making the patient understand that they require binocular vision, so vision therapy. So basically, how difficult do you find to convince a patient, and how do you approach with it, basically, especially in the cases where, you know, it might take a long time for the improvement in the patient to feel the change?
You want me to answer that?
Sure, sir.
Okay. It doesn't take time for me to explain to the patient at all, because first of all, when they come to me, they know they are coming for a problem, coming with a problem, and they require treatment. So let us say they come to Ajit's hospital, where it's a generalized hospital. A little bit of time is required to explain the problem, where the problem is, and then I'm sure the patient understands, because he has come for treatment. He has come for relief. So if he comes with a headache and Ajit explains to him, or Sarina explains to them, to the patient that, yes, this is your problem. And it is not the spectacles alone which is required. You require something else also. I think most patients will be agreeable to that. And I don't think there's anything very difficult to make them understand and make them accept the treatment. The second part, what comes is the duration of the treatment. So, well, cancer can take the entire lifetime. So that's there are certain things which a person has to do. And yeah, so when we are talking of vision therapy, it need not be in-office therapy alone. I think Marc can answer that question much better, because in US, they do not call the patient every single day to the clinic. So the patient does a certain amount of vision therapy, probably about a day or two a week in office, and balance he's doing at home. So it's nothing very difficult, and it's quite affordable right now. Ajit says that in Nepal, it's covered by insurance. So in India, it is not. And I'm sure in US also, it's not. I don't know about Australia, but in India, insurance doesn't cover vision therapy.
Dr. Marc, anything you would like to add over here?
I think the key to the key is getting the parent and child on board. You could you could diagnose, like a rock star and know that they need the therapy, but if you don't have a child or a parent who is a willing participant and sees the issue, you can do all the Brock string you want. It's not going to make a difference. If you need to meet the child and the parent where they are. So many times for us, what we'll do is we'll make that initial diagnosis in our primary care area, and then bring the patient back for further testing, just in the nature of timing and sometimes bringing them back is a way of figuring out whether they're on board. If they don't come back for the second visit, they're not going to be very good vision therapy patients. So, but meeting them where they are, talking to the child and the parent of, well, when your child tries to catch the ball, they're not doing a very good job. Would you like to catch the ball better? Would you like to have school be easier so that you don't have to struggle as much, and you can be in the upper level classes with your friends? Finding ways to meet them and to motivate them is, I find, to be the key.
Sometimes in these cases, the changes, they come slow. So sometimes patients might get impatient, while carrying on with their therapy. So how do you manage with those patients?
What I do is, and I think you have to set the scene for what is to come before therapy even starts. My therapy generally is anywhere between 24 and 30 visits for a basic case. I think it takes longer and longer. I was taught that it takes 12 to 15 visits for a very basic case. Unfortunately, the longer I practice, the longer my therapy becomes. It takes, for a 10-year-old, it took 10 years for them to try to make these adaptations, which are not working anymore. It's going to take me more than 12 visits to break those down and build them back up again. So I set the stage for, if it's, say, a 30-visit therapy program, the first 10 sessions, I'm breaking down what you did. The next 10 sessions, I'm starting to give you those tools to put it back together again. That's where we're going to start to see some basic change. And then those last 10 visits, that's when we're going to be really seeing those changes. So you have to have patience, and the more home therapy that is done, the quicker things are going to happen. So I'm very, very honest with kids. I'm honest with my own kids. So I'm going to be honest with kids in the therapy room. If you don't do the homework and your mom or dad doesn't bring you, you're not going to get better.
Sir, what in Nepal, I think in India, is the problem. Main thing is that most of the students, the patients are school-going patients, and it's difficult to attend the school. So I have got few patients. They tell that in this holidays, let's 15-20 days, they will come and do everyday vision therapy sessions in office, and they want to go home, and after 2-3 months they'll come again for 15-20 days. How do you think that in that way we can do, or it will be effective? What do you think, sir?
I definitely think it can be effective. I think the key is also the maintenance therapy in between those opportunities. Even if they can do therapy, 15-20 minutes a few times a week to maintain what you've done, and maybe even build on what you've done. Say, for example, you're able to give them a lifesaver card, starting with stage 1, and then move, as the weeks progress, setting up your program with the knowledge that you're going to have those kids or those patients that are on a month and then off, away for, set up your home therapy with that knowledge, based off of that kind of program. I think it can be effective. It's a different model. And if that's what your patients need and want, you can adapt to that model for those patients.
I just need to want to add something over here. In India and Nepal, when we talk of home therapy, it is mostly understood as software based. So it need not be. I mean, you could make a customized package of a few things and give it to the patient and see to it that the patient does them. It's not necessary that it has to be software based and the patient should have an internet connection, etc., etc. So I think we have to change our thinking a bit, where when we say home therapy or even in-office therapy, in India and Nepal is something like, if you have a computer-based system, then you can do vision therapy, otherwise you cannot. So that's not true. Vision therapy can be done with a minimum of costs. It's not really necessary to have phenomenal, should I say, investment into the systems. Yeah, if you have it, perfectly fine. But if you don't have it, it's okay. You can still do vision therapy.
Thank you, Dr. Aditya Goyal. Similarly, coming towards the referral system, so we work in sync with ophthalmologists to provide eye care. So how is the referral system between ophthalmologist and optometrist for binocular vision cases?
Marc, would you like to answer that question before me?
Sure. Optometry struggles with getting referrals from several different sources in the US. One of them, of course, is ophthalmology. And that's for a very good reason. Ophthalmology is taught it's a surgical profession. They are taught to correct issues in a surgical manner. That's their training. So the concept of vision therapy and the concept of using lenses and prism and it is just so foreign to them. Unfortunately, in my career, I've had one ophthalmologist who has given us some referrals. Unfortunately, he moved away 10 years ago, so we don't really have a very good relationship, but we're always trying to build it. The second group that we suffer from referrals is optometrists. And sometimes I'm kind of at a quandary to understand why. Whether it's because the system has gotten more commercial and they're being asked to do more in a shorter period of time and they're skipping some of the tests. And that's kind of a quandary for me. But we get great referrals from occupational therapy, physical therapy, speech language pathology. So we're get from some of the ancillary sciences. I think, when I get a referral from anybody, I think it's key to send a letter back, send out correspondence. Even if it's, think about your primary care patients that you're treating with diabetes. Isn't it important to send correspondence back to the primary care physician, letting them know that, visually and retina-wise, everything is looking good? Why wouldn't you send back information to the child's primary care physician that they've been diagnosed with a binocular vision issue and you're treating it? So I think that's how you build your referral network.
Dr. Celine, anything you would like to add regarding the referrals?
I think the situation in Australia is quite similar to that in the US. I think the only other referral source I can add is school teachers. They have children in their classrooms who have gone through vision therapy, found great success, and then they in turn refer patients to us. So that's fantastic.
Thank you, Dr. Celine. I'd also like to come to Dr. Sarina. Anything you would like to add about the referral system in Nepal?
In context of Nepal too, the referral of the patient requiring vision therapy from different eye hospitals is very low and unsatisfactory, to be truth. However, within a certain group of people, it is okay.
So, okay, now
Just,
from Indian perspective, sorry, Ajit, continue.
Sir, I want to add that in contrast to the US and Australia, in Nepal, the relation between optometrist and ophthalmologist is, I will say it's very good until now, palatable. I don't know, maybe optometry field has not developed that in Nepal. So what we are doing here is, in like any ophthalmological conference, we are, and some papers are being presented from BV and this vision therapy as well, and so the people are knowing about vision therapy, ophthalmologists. And yes, we are. Personally, I am getting 2-3 phones from ophthalmologists from nearby hospital that I'm sending you a case of this amblyopia or this. So please just evaluate him. So what I do, I just examine the patients and I do the needful, and I get back to them again. This was the case, and I examined this, and this I did for that case, and that's why the relation has been palatable till now. And that's why we are proceeding in my hospital in Baltimore. That's how I am proceeding, and it's going good. The referrals are good. I'll tell from ophthalmologist.
Okay, in India, contrary to what happens in US and possibly Australia also, it's a little different where most of the ophthalmologists want to do vision therapy because it adds up to another source of income for them. But unfortunately, they are not trained. Like what Marc said, they're all trained to be surgical specialists, surgery specialists. So they'll want to do vision therapy because they hear from different sources that this works and they want to try that out. So invariably, most of the ophthalmologists employ optometrists, and to some extent, optometrists do that. And a number of eye hospitals across India, they do practice vision therapy where, of course, there's always a friction about the philosophies of vision therapy and how it is working, not working, but then they do vision therapy to quite an extent in India. So ophthalmologists, basically, like what Ajit mentioned, in ophthalmological conferences, there are a lot of vision therapy cases which are presented and discussed, and a lot of programs have been created by ophthalmologists along with optometrists. But as such, I would not be able to tell you how much they believe in vision therapy or not. But then, yes, they are not like in US. They are totally anti-optometry, anti-vision therapy. They are not so over here.
Aditya, are they doing vision therapy or are they doing orthoptics?
That's $1 million question you've asked now, and that's a confusion which I have been clearing for past 20 years, but I have not been able to do that. I've not been successful even with optometrists, forget ophthalmologists. So when we, I'm sure when we began the program, she mentioned binocular vision and orthoptic evaluation. So they don't do anything right now. They used to do orthoptics with synaptophore, but right now they leave it to the optometrists to do vision therapy. But the optometrists in India are quite confused between orthoptics and vision therapy. So I think it's a big task for us to clear that out. I hope with my students, I've been able to clear to an extent, but then hopefully it will clear out over a period of time.
Would you like to clear it for our audiences, sir?
Do we have time for that?
We can be concise.
That might take a long time.
So we are in lockdown. You can tell briefly. Lockdown is lockdown. We have ample of time.
The lockdown version.
So in a very, very brief way, there's a difference between pencil push-up and Brock spring. So Brock spring, like what you guys used to practice, and I always used to scream at you in the college, where you were asking the patient to look at the bead and counting 1 to 100. That's not what Brock spring is actually about. So I always used to say, look for physiological diplopia, making the brain understand the single and the double, right? Yes. But when we work with pencil push-ups, that's pure orthoptics, where you're just getting the pencil in and making the muscles work. Vision therapy is not making the muscles work. Vision therapy is making the muscles, making the brain understand how to make the muscles work. Very brief, but then that's what I would like to say.
Thank you so much, sir. We'll just take a quick question from our audience. Mr. Mehdi Hassan asks, he would like to know the treatment options from vision therapy clinic for special children like Down syndrome, autism, and dyslexia. Where do we start, sir?
I mean, to be honest with you, and I do see I think the next question is related to neurooptometry. So yes, I'll take both of them because the answer is the same. What you do for your patients, your traditional therapy patients, you simply have to modify the parameters, and you can use them for any patient, whether it's neurooptometry, special needs. You just have to alter the parameters and change the inputs and find the level of success for that patient. And it's the same thing for sports athletes. You're just now raising the level of difficulty and challenge versus a special needs patient, you're lowering those parameters. So almost any activity can be changed to be part of a therapy program for a patient with special needs. Obviously, in some cases, with highly autistic patients, you're not going to be getting them on a Brock string, but you could be using large puppets. You could be using flashing lights. You could be using large balls. You just have to find what kind of keys into them, and obviously the ceiling for improvement is going to be much different as well. So you just have to kind of change the parameters, and you can find success on some level with almost every patient.
I'd just like to add something. There's a feeling that we can treat Down or autism or dyslexia with vision therapy. We cannot. We cannot treat Down or dyslexia or autism or any of these conditions with vision therapy. We are only working on the visual symptoms, visual areas, and ease the thing down for the patient. Even when we talk in terms of spastics, we are not treating spasticity. We work along with the other team. So it's not a singular system. We need to work as a team with other specialists to help the patient. So it's a wrong thinking and wrong feeling that we can treat all these conditions with vision therapy. Sorry, we cannot.
We just help those the people with those conditions function better by developing their skills, current skills. Am I right, sir?
And yes, so when I'm working with vision therapy on a patient who has spasticity, it helps a physiotherapist or physical therapist to help him better. So the results are better and the patient is able to improve faster. But we cannot treat cerebral palsy, right?
Thank you so much, sir. Similarly, I'll just take another quick question from our audience. I'd like to start with Dr. Celine here. In case of pediatric patients, it's hard to get accurate results from the tests whenever the patient is especially not very cooperative. So could you just give us some suggestion to improve that part?
Of course. So the key thing that I learned was that you don't have to do everything in one visit. It's okay to separate in different visits. So, you know, if they can only do a cover test today or just an NPC today, that's fine. Try again another visit. When the child gets more comfortable with you and you get to know the child a bit more, you can tailor your testing to them. So keep going. You don't have to do it all at once. Take your time.
Thank you, Dr. Celine. Dr. Marc, anything you would like to add over here?
No, I totally agree. You know, there are definitely days where, you know, you just have to look at the parent and say, you know what, let's try again another day because it's not working today. You know, let's try a different time of the day. Let's, you know, maybe don't let the child take, you know, don't wake the child up from his nap, you know, before you bring him in. But then, and I would also agree that, strangely enough, visual acuity is almost kind of like the last thing I care about in the exam, because you're getting the data, the same data from other points, especially your retinoscopy. Your retinoscopy and your cover test, you know, you're going to know whether that acuity is good or bad pretty much based off of that. So, you know, getting the acuity is kind of the icing on the cake.
Dr. Aditya, you also work with pediatric groups. So anything that you would like to suggest to our audience here? Sir, we might want to unmute the mic.
Sorry, I just mentioned that I don't like to force any of the tests on my patients. So if a child does not want to do it, he doesn't want to do it. How much ever you try, it's not going to happen. So call him another day. Give him some time off. Let him go out and play and then come back to me. So if you try to do all the possible tests in the literature, you're never going to be successful with the child because they are totally moody. They don't want to answer something, they're not going to do it. So you have to be patient with them, and you don't expect them to work the way you want to work with an adult. They are quite different. So that's how I like to work with kids. So if like what Marc said, I like to go by my gut instinct and again my objective tests and see what they're seeing. Objective tests never lie. Secondly, one more thing, just believe in one thing: the child never lies. If he's seeing it like that, he is seeing it like that. He's not going to lie about it. We possibly don't have the ability to understand or interpret what he's saying. It should be considered as our inability rather than the child's inability to give responses for your tests. A number of times we say the child cannot respond to these. Sorry, it's not so. We possibly do not have the ability to get that response from the child. But then don't force the test on a child. Go ahead and do whatever possible and try to make sense out of it.
Thank you so much, Dr. Aditya. Now I would like to move to Dr. Sarina for my next question. So for a country like Nepal, where we have a limited resources, what do you suggest, what instruments do you use for the therapy? And is it based more on the availability or not?
Well, I have used different instruments and software as well, including BTS4, SBI, VisuPrime, and instrument. I've used a number of instruments, aperture rule, borniloscope, triangle, but I prefer Brock string the most. And yes, it is based on the availability as well. Brock string, it is cheap, and I can make it on my own. And most important, most of my patients can afford it as well. I can make it with the help of around 10 feet long white cord, and all I need is 3 different colored beads, and it can be used in different type of conditions, and we can improve a number of visual skills as well with it. And talking about you starting a vision therapy in context of Nepal with limited resource, we can always start vision therapy even with limited resource. We can always use a heart chart. As I said earlier, we can use Brock string, and even I have been using self-made Marston ball till now. Uh, I just got the Bornal Marston ball this March when I attended the symposium done by Dr. Marc Taub in Bangalore. And we can always use lens blank and prism for improving different visual skills. So yes, with the limited resource as well, we can start vision therapy.
I remember one lecture from Aditya sir. He questioned us, how much investment do you want to start a vision therapy clinic? And we guessed a lot, but he told that you need only 150 rupees. You need just a red green goggles and 2 red and green sign pens, marker pens. That will do, and broadcasting. So yes, I think now I'm understanding a little bit. Yes, he was right, and we can start from there. Thank you, sir.
I think the two of you have really highlighted that the absolute most valuable thing, even money can't buy, is knowledge and knowing how to use what you've got. And I find that even though I've got all the software and fancy stuff and VR goggles, I still resort to the more traditional things like the Marsden ball, fixation targets, Brock string, my favorite, and the heart chart. So props to you, that's fantastic.
And if you try to go for a proper VT setup with all the equipments, it's only going to cost us a lot of money, and it will just hike the vision therapy price up.
If you ask me, you can have all the equipment on earth, which I don't think anyone has, but then you could have all the equipment on earth and do horrible vision therapy, and you could do fantastic vision therapy with what just Ajit mentioned, probably about 150, 200 rupees, and you could do fantastic vision therapy. So vision therapy does not depend on the equipment. It depends on what you're doing and how you're doing it.
Thank you so much, sir. Thank you so much. Moving on to the next.
We can't hear you, Manashwi.
Okay, I'd like to ask this question to Celine specifically. You've been very close to Nepalese optometrist, and in terms of practice and scope, what differences have you seen in Nepalese and Australian optometrists?
So I had the pleasure of working with Richan Sherpa, Tashi Sherpa, and also Eugene Tamang on the Eyes Forever trip. So I think one of the biggest differences is that in Australia, when we graduate, all the optometrists meet the same guidelines. So we all graduate with pretty much the same skills. However, in Nepal, I found that there's a huge range of skills with most optometrists, but they're so eager to learn. That we were doing ocular health, and they were eager just to, hop on the BIO, try the DO, try the red, and do all these different things. I think the other thing that's quite surprising to me was that Nepali optometrists are really good at switching and adapting to different cultural situations, and I really valued their closeness to patients. So I was working with Richan and Eugene. They were calling the elders that we saw like sister, big brother, like Dai and Bai and Didi, which was so cool to me, because in Australia we tend to keep this sort of medical professional distance sometimes. So they highlighted how important it is for us to be close to our patients to provide the best care possible.
Thank you.
Yeah.
Thank you so much, Dr. Celine. So moving on to the next question, I would like to start this from Dr. Marc here. What are the chief challenges in the field that someone who wishes to practice VT may experience, and what would your suggestions be to tackle those those challenges?
Strangely, I just happened to write an article that was published a few days ago in the journal called Optometry Times, and you could just search and you can find it. And it was an article that I wrote on kind of the 10 things that I wish somebody would have told me 20 years ago when I was starting down this road. And probably the number one is education. You as a doctor of optometry, optometrist, you can't ever stop learning, and you must embrace the concept of lifelong learning. And in this area, there is so much good education, and beautifully, through things like this, through online platforms, if you are in countries where that education is not as easy to access. Learning is so crucial. Don't forget, we are a visual profession, so there's this thing called reading. There are great resources from ACRO, from OEP, to get some of those classic texts which have set the stage for so much of what we do. Online learning, like the journal that I edit, Optometry and Visual Performance, COVD's journal, Visual and Vision Development to Rehabilitation, is so important. So just constantly learning. I think the second thing is, and I mentioned in that article, don't jump into the really hard cases. Start with cases that you can be successful at. Don't start with the 40-year-old constant esotropia that they've had since birth. Don't start with the 5-year-old autistic nonverbal patient. Start with a basic CI. Start with a basic accommodative case. Find success. Those would be my two kind of key points.
Thank you, Dr. Marc. Anything you would like to add, Dr. Aditya?
Yeah. Education, the first thing. Second thing, get the fear out of your head that binocular vision and vision therapy is a very, very difficult thing. It is not. It's basic understanding. If you just understand very basic principles, it's very easy. A lot of people are given, they think that understanding vision therapy or binocular vision is very difficult. It's not so. So get that fear out of your head and you can definitely do it.
Thank you so much, Dr. Aditya. Now, I'd like to ask the same question to Dr. Ajit. Anything that you would like to add over here?
No, I don't want to add, but I want to ask my queries to Dr. Marc and Aditya sir. You talked about online resources. We are hardly getting online resources to read on this vision therapy. So I request you to share those online resources to us, to Latest Optometrists. First part. Second part, I was thinking of that. Nowadays, the maximum people have smartphones. Is there anything that smart home vision therapies that can be done through smartphones in US or Australia that everyone can do at their home, just in a smartphone? Is there anything that is being done in vision therapy through smartphones?
I don't believe, I have not seen any. I mean, I haven't really seen a whole heck of a lot through a smartphone, but I'll be honest, even if there was, I don't think that would be a platform that I would find use for. so much of what we do in the world is stuck at this little space right here. And I think that leads to so much of the issues that we're seeing binocularly. And I want to get kids away from the smartphones and away from the tablets, away from the computers. And I want them, I want to kick them in the rear ends and get them out of the house and introduce them to this thing called a ball. And this is how to get them away from all of that stuff. So I'll be honest, I'm not a big fan of using a lot of the home, the computer-based programs too much. I want to get them away from that. I want to get them out into the world and learning how to use their vision. So even if there was one, I don't know if I would use it.
Thank you so much, sir. Right here, I would just like to put in another question by our audience regarding the smartphone users and the VDT users that we see on the rise right now. So what would be your advice to the practitioners that prescribe the anti-fatigue spectacles with mild plus vernier zone for young patients and pre-prescribes without actually doing the binocular vision workup?
There are some cases where a little bit of plus can actually make things a lot worse. Let's say an X4 reacts a lot to plus, and that just pushes them out of their zone of comfort. So, if you have the tools to do it, definitely do a bit of a BV workup and binocular balance. Don't just prescribe blanket anti-fatigue to everybody. What are your thoughts on that, everyone else?
Not everybody needs inserts for their orthotics for their feet. Not everybody needs braces for their teeth. It makes little sense to prescribe something without doing the testing.
So I would not like to give it prophylactically, like everybody on earth given plus lenses plus 0.5. No, definitely not. And for the people who do have non-strabismic binocular vision anomalies, so this will be more like a paracetamol that you're providing without providing any treatment. So you don't even know what you're treating. So just because these manufacturers are talking about anti-fatigue lenses, it's not that it is necessary to be given to everybody and everybody is going to benefit with that. So there's no one fit suits all.
So it's not prophylactic, it's profitability. It's profitable only.
Prophylactic profitability. If you want to do that, that's a different question, but then.
Profitable to whom, actually?
I don't know to who, but then let's avoid that.
Yes, let's avoid that.
So coming to the another question right now. So how frequent do you see the patient inflow for the binocular vision in the VT clinic? I'd like to start from Dr. Aditya Goyal.
Since I have in my private practice, it is pure vision therapy. So we do get referrals. Unfortunately, we do not get from ophthalmologists and optometrists. We get from all other people apart from ophthalmologists and optometrists. They don't like to send too many patients to us unless they are not able to handle them at all. But when we are, if I talk of the hospital, in hospital, yes, we do get plenty of patients. So it's a very good inflow of patients that we get. I think your mic is on.
Thank you, Dr. Aditya Goyal. I'd like to ask the same question to Dr. Marc about the inflow of the patient for the binocular vision.
You're asking how often I see these patients, or how often I physically see them in the office? Like, do I do my therapy once a week, or I'm trying to tease out the question a little bit.
How often do you, no, I'm basically asking the frequency of the patient that you see in general in the VT clinics.
Oh, okay. So, I see the patients the way I work at a college of optometry, And we, the way we traditionally do it is we get referrals to our therapy clinic. So our patients come from our primary care service or they come from outside referrals. And we will see them and determine a need for therapy. If therapy is needed, we see the patients once a week, and we do home support with our therapy. Very rarely will we do every other week therapy, but those are more long-term patients or patients with special needs in which the parent is helping significantly with the therapy. And it's a challenge to get the patient into the therapy room. But most of our therapy is once a week.
Thank you, sir. Thank you for the answer. Now I'm moving forward to Dr. Sarina. You work in Drishti Eye Hospital. So how often do you see patients who specifically come for the vision therapy?
At the time when I started vision therapy, which was around 4 years back, of course, obviously, at that time, the number of patients coming for vision therapy was very less. But now we have a good number of patients for vision therapy. We have 2 fellows under me, and we run around 25 to 30 vision therapy patients in a day. And we have around 10 binocular vision assessment in a day. And the major problem in this is that our clinic hours coincides with the school hours and office hours. So there is actually crowding in certain period of time. And to increase the number of patients, we are planning to change the clinic hours as well. And in my clinic, we usually see NSBVD patients, convergence insufficiency, divergence insufficiency, such type of patients, and lots of amblyopia and squint patients, stress patients.
Thank you, ma'am. Moving forward to Dr. Celine, what is your take on this?
I see the vision therapy patients myself. So I see about 4 to 6 patients per week. And I see just regular patients in between.
Moving to Dr. Ajit, you work in a hospital in Jhapa. So how often do you see the patients who are in need for the vision therapy or binocular vision assessment? And how often do these patients seek out the therapies?
I usually get around 5 to 6 cases in a week because I don't do vision therapy that much. I'm involved in other part as well. So I think regularly I'm getting 5 or 6% a week who are doing therapies under me.
Thank you so much for the answer, sir. Now coming to the emotional aspect of our practice here, what is the best reaction that you have gotten from your patient to whom you have given the therapy? I'll start with Dr. Marc.
Over the years, I've had some really neat patients. Everybody's had those aha moments, but I think it comes later. I treated a patient 15 years ago now, and he came to me and he was struggling in school. And actually, no, I'll tell a different story. This is a patient from a few years ago who had been struggling in school. He was wanted to go into college, specifically like a technical school to repair air conditioners. And he had been struggling his entire life and had been given more and more and more prism. He had eaten up his prism. He was a convergence insufficiency, and he had struggled his entire academic life. And at the age of 18, found his way to me. And I actually had to apologize to his mother and to him because of the mistreatment that he had gotten from the hands of another optometrist, giving him more and more and more prism and struggling academically. And in 18 weeks, he finally got the treatment that he deserved and he needed. We really got him back on the road to being a successful student after struggling for 15 years. So that was, you know, I don't like to often make parents cry, but this was, you know, a cry of relief that the mom had finally found something for her son and he didn't have to suffer anymore.
Thank you, Dr. Marc. Similarly, I'd like to ask Dr. Aditya Goyal to share his experience of any wonderful reaction that he has gotten from his patient of to whom he has given the therapy.
Oh, plenty of them. I'm sure you must have seen that in the college also. The number of patients who come and the parents, the reactions, and when they. But one I can never forget is an autistic patient who was referred to us, and she was walking on toes, and she had never walked on the full foot down on the floor, and we just put in prisms and she was flat on the floor, and they were like, parents were totally amazed as to, it was something like a magic that had happened. Okay, I'm not going to say that that is what I'm going to prescribe to the patient, but then yes, we could make those subtle changes wherein we have brought about a number of changes in the patient's life. What we have done, more importantly, like Marc was mentioning about the prisms, very often in India, what I see is minus, a huge amount of minus being prescribed. And we've had cases in the hospital as well as a clinic wherein the patient was being treated by our optometrist, given minus over a period of years. Minus had increased to almost about -5. And when we saw him in the VT clinic and we started working, and he happened to be a hyperope of about +4 to +5. So those are the cases that we see on a very regular manner in India. So a lot of most of the parents and the patients, they are very happy about the outcome, very happy about what is happening. But then vision therapy brings about very slow and subtle changes. So it's not that you're going to make an immediate change and the patient says, wow, this is fantastic. So yeah, we do find a lot of improvement over a period of time and the patients are happy.
Thank you, Dr. Aditya Goyal. I'd like to move to Dr. Celine now. What would your experience be?
I think I celebrate every single time my patients have those little aha moments inside the vision therapy room. Similar to Dr. Goyal and Dr. Taub, I feel like the vision therapy changes, the big changes that you see actually come maybe even 6 months, a year, or even 2 years afterwards. So following back on those patients who I just started with 2 years ago, it's just, you know, little things that they tell me, like, look, he's scored his first goals in soccer, or, you know, he can't stop reading his books when they came in for, you know, not reading at all. So that's always fantastic. Everybody's a little bit different.
So especially the little moments that give them happiness, make you happy.
Of course.
Thank you, Dr. Celine. Moving to Dr. Sarina, anything that, any moment that you would like to share when you felt really emotional seeing the response of the patient?
Well, I also have a number of patients who were quite satisfied with the vision therapy. There was a patient who went to a renowned hospital here in Nepal, and he was told that his vision will not come back, that he is amblyopic and nothing can be done. There is no treatment. He was quite sad when he visited us. But when we said that, yes, it can be treated with vision therapy, he was quite happy. Even then he was happy. Then when he got his vision back, he almost cried.
That was really, really very sweet, ma'am. I'd like to talk to regarding the same, if any experiences that you have had that made you emotional.
I have both experience, a scary experience as well as good experience.
Let's hear about both, sir.
Yeah, I'll tell. Just first one, just talking on good experience. There was a nystagmus case. The amount of amplitude of nystagmus was dampened in a period of time, and that was very interesting. And The girl was very, very happy with that, her parents, and it gave me so immense pleasure. And the scary one was superior oblique palsy case came to me, and he was complaining of something diplopia and this poor head posture something. And at first visit, I did prism adaptation test all, and I give this very low amount of vertical prism. And in a period of time, in 2 months of period of time, I told him to change thrice that prism power, because the power every days I was giving him version 6 as well for the vertical versions. And in 2 months period of time, I told him to change the glasses thrice, and he was very angry. This, it costs a lot. It cost me a lot. Why are you just changing every month, every 15 days? And sometimes we get a very scary experience as well as some good experience. I have both of them, so it's good.
Thank you, Dr. Ajit. Would you say that would be the most challenging case that you've come across with, or do you have another story for that?
I have a case that I want to discuss with our this panelist. A child of 7 years, 7 year was there. See, he was isotropic, right? I was isotropia, and when we refracted him on encyclopedic, it was +7 diopters, but he was plano with 6.6. He was plano with 6.6. We started pushing him plus. I gave him +3 at the beginning. The vision was 6.6 partially. It was blurred. Vision was blurred, but still I gave him 3. And period of time, I try to push. The isotropia has a little bit reduced, but it has not gone all. And we are able to push till only 4 diopters. What is your plan on that? From the expert, I want to just listen. How do you proceed?
The eye turn, is the eye turn the same at distance and near?
No, it's a near is more.
So I definitely love the approach. I will say, I'll correct you in saying pushing the plus. I don't ever push anything except my children to do their homework, and it doesn't go very well there either. You want to set the stage for them to almost kind of accept as much plus as they can. So I think I mean, the trick is to reduce the amount of the turn using the plus. So whatever plus that they'll accept without, even with a little bit of blur at distance. And what you might want to consider is using a bifocal at near to further reduce the eye turn at near, because they've got so much accommodation. They should see clearly through almost anything you put in front of them at near. So you said that it blurred the vision. Was the vision blurred at distance or at near?
It was for distance. We tried a bifocal as well for him. We added 1.5, 2 diopters for near.
And did that reduce the eye turn even more?
Yeah, a little bit, not fully. He is now, I think, previously it was 30 prism diopter. Now he is around 20 prism diopter, I think, 18, 20.
That's definitely a good start. I mean, the other thing you can do is you can use binasal occlusion. Is it a monocular eye turn, or does it alternate?
It's alternate, sir.
So I mean, you've got the, I mean, binasal occlusion generally is used to get the patient alternating. So, I mean, honestly, what you really need to do is you need to start getting them into therapy so that they can understand what fusion feels like, so that you get that fusion point, you build at that fusion point, and if you can get them to understand what it feels like to have binocular vision, then you can start expanding it to, expand the ranges out, because if he has no concept of what it feels like to have both eyes pointing at the same place, there's no reason for him to ever want to do it. If there's no benefit to him, then he doesn't perceive the benefit, then what's the point?
One thing just I wanted to ask, just I shared with Aditya sir, there is one concentration that atropine 0.01%, it is available for myopia control, atropine 0.01%. It's there for myopia control. Can it be helpful just in accepting plus power in this child? What do you think?
You want to give atropine for him to accept plus power?
0.01, yes, for acceptance.
No, I mean, why do you require atropine for him to accept plus?
Actually, he's not accepting plus.
That's like okay. Like what Marc said, if he's not accepting, he's not accepting. It's okay. But then I don't understand the reason why you want to use atropine for him to accept plus.
What I think he is not accepting because there is accommodative access, and I want to relax the accommodation. That's why it will work or not. That's why this is my question.
I personally would not like to do that. Okay. Just tell me something. Does he have suppression? Is he suppressing?
Actually, there was in binocular condition there was suppression, alternate suppression.
Sorry, I didn't get you.
There was alternating suppression as he alternated.
Oh, he was alternatingly alternate suppression was there. Okay. Personally, I would not put him on atropine. What do you say, Marc?
Oh, I totally agree. I think you give the most appropriate prescription based on the most plus that you can give at distance, just kind of at that blur point, and then give more at near. And then again, you're totally correct. There is an accommodative problem without a question. But even if you atropinize and you get him to accept the full plus, you're still not going to treat the binocular issue. The child is still going to suppress because he has, I don't know if it's a he or she, I'm just keep going to he. He has there's no benefit for him to not suppress. He doesn't understand what it feels like. So if there is no understanding and feeling of what this is supposed to be doing, he's never going to get to that point. So you can straighten the eyes with as much plus as you want. His brain still doesn't know what to do with it. Do you agree, Celine?
I completely agree with you. I think you're doing a good job with what you're doing, but get them into the therapy room. The other thing I wanted to add is the atropine concentrations for myopia control, 0.01, 0.02, 0.05 as well, don't have a cycloplegic effect on accommodation. That's why they can use it every night. So even if you give them that, it won't work out. So, higher concentrations like atropine 1%, that would definitely knock out the accommodation if that's what you're using it for.
Thank you, Dr. Celine. I'd like to ask you the same question. What was the most challenging case that you have come across with so far?
I think the more challenging cases for me as a newer vision therapy practitioner is definitely the amblyopic strabismus. So let's say somebody with a partially accommodative esotropia with amblyopia. So still working on those cases, and I'm lucky to have mentors to guide me through that.
Thank you, Dr. Celine. Now I'd like to move to Dr. Sarina to ask her the same question. What was the most challenging case that she has come across with so far?
Well, I would like to discuss a case too over here that presented before 4 to 5 months back in our hospital. There was a boy around 12 years that presented to us with a complaint of blurred vision at both distance as well as near since around 3 to 4 months. And his vision was around 20 by 400 in both eye. And he was complaining of intermittent double vision and headache. And his cover test, he showed alternate esotropia. The retinoscopic reflex showed unstable reflex and variable myopic reflex. It was grossly -8. and dynamic retinoscopy showed lead of accommodation. And we did cycloplasic refraction in this case, which showed plus 0.5. So with this, we came to a diagnosis of accommodation spasm. And in this case, we did modified Boris delayed subjective refraction, but vision didn't improve. Vision improved up to 20 by 100 only. So then we gave +2 diopter of addition lenses for NAIR and followed the patient after a month. In a month, his vision was only 20 by 60. Then we gave him vision therapy. We gave him Brock string and accommodative facility training as home-based therapy. Then we have called him for follow-up. Next follow-up we haven't seen. So what else can be done in such kind of cases? So any additional things that we can do?
I think in my head, the alarm bells are ringing for anything ocular health related, such as, you know, let's say keratoconus or, God forbid, something like a brain tumor. So I would definitely get a full investigation of that, whether you have access to MRI, CT scans, something like that. Or if there's anything that's going on systemically as well, like, is he well? Is he getting headaches, fevers? What's going on there? It seems quite unusual.
Headache was there.
I think you also have to look at the emotional health of the child. You know, this to me is kind of screaming, not a traditional Streff syndrome. The acuity is pretty stinky, but given that accommodative fluctuation, I would look at, you know, things like the visual field. I would look at color vision, some of those things to rule out some of the Streff syndrome kinds of things. But I think you're on the right target. I do. You know, originally when you started going down the path, I was like, oh, you know, oh no, oh, somebody's got some noise going. Oh, hold on. Okay. When you were originally talking and you said, you know, a 12-year-old with an esotropia, I was like, oh crap, that's not going to work out very well. So my mind went down the same pathway you were going down, Celine. I was like, yeah, this is bad until you prove it otherwise. But I've seen cases like this with this just extreme spasm of just I think if you a mixture of plus lenses and traditional therapy, and try to get down to all of a sudden this happened. Like, what happened? Did something emotional is happening with this child until you prove it otherwise? It could be the parents are getting a divorce. Maybe somebody died in the family. Something happened at school. Something set this off. You just have to figure out what it was. And sometimes that's not that easy.
Yes, of course.
Thank you, Dr. Sarina. Now I'd like to move to Dr. Aditya Goyal and ask him to share his experience about the most challenging case that he has come across.
The challenging cases?
I believe the cases that you see on daily basis would be the most challenging for a lot of us, but
The most challenging case was, I would say, I think this girl was perfectly sighted girl, about 14, 15 years of age, and had a bout of tuberculosis, and after that lost vision completely. And she came to us with all the possible hopes and telling her that possibly nothing can be done. So telling a person that nothing can be done, where they come with a lot of hopes and believing in a miracle, that's one of the most challenging things for me to do. And I think that is something which most of us medical practitioners go through. I think more than being successful or unsuccessful in any case, it is giving the bad news to the patient, which is most challenging for me.
Thank you, Dr. Aditya. Now, I'd like to go to Dr. Marc and ask him the question about the most challenging case that, according to him, that he felt.
This was a patient that we just saw in the last 7 or 8 months. So this this young woman, she was 25, 28, 30 years old. She comes in and she is got this complaint of just, she's got these facial tics. Every time you ask her to move her eyes, there's a little nystagmus, and there's this, like, you ask her to just fixate on anything, and there's this like kind of facial tics, and she's almost in pain when she's doing this, and you ask her to fixate, and she's kind of just almost, her whole body is tensing and spasming. And she had been to neurologists, and for some reason nobody would scan this poor woman, and we end up finally getting a scan, and it ends up that she has a condition where I forget the exact name of it, but her brain is actually swollen and coming out her her foramen magnum, and it's I forget the exact name of the condition, and this poor woman has been like suffering for years. Nobody would believe her, and nobody would just do the darn MRI, and we got her over to the neurology group, and like they were like, holy crap, when they saw the scan, like, oh my gosh. And she ended up having surgery, and that's relieved some of her discomfort. But because things had been going on for so long, and she suffered for so long, it's taking a ton of time for many of those symptoms to go away, and they may never. So this was a beautiful case of neurology and you know, knowing where things happen and what the possible causes could be. But you know, this was definitely one that was not a VT case. This is a neurology case. So that was one of the most interesting patients I've ever seen.
Thank you, Dr. Marc. Now we've come to the final questions. This may seem a bit irrelevant, but how much do you charge for each session of therapy?
And thank you, Celine. Yes, it's a Chiari malformation. Thank you. It's really early here. My brain's not really working yet. Yeah, and it was so, because we got the scans and you're like, oh yeah, that's not supposed to be there.
Oh my goodness.
Oh yeah, and it had been years. Yeah, and she just been to 2 or 3 one neurologist and her primary care, and you just felt bad for this poor woman, just suffering. Yeah, it was pretty stinky.
Yeah. Well, in answer to Minashvi's question, I can't speak for everybody in Australia, but in terms of charging, insurance does not cover vision therapy in Australia. So a normal session would be from around 30 minutes to 60 minutes. And I've heard ranges from $60 to $120 an hour per session, sorry.
Thank you, Dr. Celine. How much do you charge, Dr. Marc?
I'm a little bit different situation. I'm not in private practice, so I'm at an academic institution. So our goal is to treat patients, but then also have patients for our students to work with. So our fee is $53 American per session for 45 minutes. And insurance is very dependent on state. So in Tennessee, it is covered by a program called Medicaid, which is for low-income individuals. But if you go across to Mississippi, it is not covered by their state Medicaid. So it's very Then private plans are traditionally don't cover vision therapy for the most part. So, but yeah. So it's a wide range.
Thank you, Dr. Marc. Now moving to Dr. Aditya.
Yeah, we charge in our practice, we charge 500 rupees, which is roughly about $6, $6 US. And that's for about half an hour to 45-minute session. So I don't know how much you charge in Nepal, but then 500 is considered to be a higher price over higher cost over here. So there are people who charge from 100 rupees, which is probably about $1.50, $1.25.
Dr. Sarina, how much is your charge for a vision therapy session?
In our hospital, the charge for vision therapy is 400 Nepali rupees, which is around $3.5 USD on average.
Thank you, Dr. Sarina. Now we've almost come to the end of the session. Just a simple question, a small question to Dr. Aditya Goyal from our audience here. How do we make an ophthalmologist understand the necessity of vision therapy for a particular patient? Because we see a lot of rivalry kind of situation going on here, especially in this particular field.
Very difficult question for me to answer because a number of times we end up having a lot of arguments on that, but then over a period of time, it's a kind of understanding that develops between various ophthalmologists. But then, yeah, it becomes very difficult for us to explain. So for one particular patient, it becomes a kind of ego issue sometimes. But then that is for general ophthalmologists as such. But if you're in the hospital, and like what I mentioned earlier, a lot of ophthalmologists in the hospital, they want to do vision therapy. So it's not a very difficult situation to do. So they say, okay, fine, we have tried everything, whatever we wanted to, now you guys try it. So it's something like last resort. The patient is sent to us, and then if we are able to do, then yes, that becomes a kind of a role model where you say, see, we were able to do that. So give us these many more cases. So right now we are working on adult amblyopia, where the ophthalmologist never believed that anything beyond 8 or 9 years can be improved upon. So today, the ophthalmological studies which are going on in our own hospital, where they're working on adult amblyopia, and for your information, it's a ophthalmology study which is going on. It's not an optometry study, but the optometrists are helping in that study.
Thank you, Dr. Aditya. I'd like to ask any other of our panelists if they would like to add something about it.
I mean, I would say the only way that I know how to enact change is by treating patients. And if I do good work and I treat patients and they've been told by ophthalmology that this is what they have to do, and I can do the same thing with a different treatment, hopefully they'll wake up. But I've always considered it my job not to convince anybody else of what I do. I just do it. I've convinced myself. I don't have to convince anybody else. I know what I do is great in terms of the therapy room and helps people's lives and helps kids do better in school and helps adults with brain injuries get back to their lives. So I don't know, I sound like an old man. I don't have to prove what I do to anybody else. I'm just going to do it.
Thank you so much, Dr. Marc. Anybody else from our panelists would like to add anything? All right, now this brings us to the end of our session today. I'd like to thank all of our panelists for a wonderful discussion and great insights. And I hope that our audiences have also immensely enjoyed this discussion. So before we wrap up, anything you'd like to add that we might have missed, or any last words for our audience?
I would just tell the audience, don't be afraid to jump into vision therapy and get started. Just don't be afraid. It's so much fun. I mean, think about it. Everybody else gets to sit and refract patients all day long, and you get to play games with them and change their lives.
Thank you, Dr. Marc. Dr. Aditya, anything you would like to say?
Yeah, I'd like to just mention Marc's words. If you want to do vision therapy, you have to do vision therapy rather than keep thinking about doing it. So go ahead and do vision therapy. You may go wrong a couple of times, but then actually in vision therapy, you never go wrong. So go ahead and do it. Don't be scared of it.
Thank you, Dr. Aditya. Dr. Sarina, anything that you would like to speak to our audiences?
I think don't be afraid to start, even if you don't know everything there is to know about vision therapy, because no one truly knows everything about vision therapy. As Marc said before, it is a lifelong learning process. So jump in, get a good mentor. There's a fantastic vision therapy community all around the world. You can find someone to help guide you if you go on a wayward path. Let's get started, really.
Thank you, Dr. Celine.
Who did you call on next?
Dr. Sarina, any words that you would like to share with us here?
So in Nepal, their vision therapy is not there. There are limited number of people practicing vision therapy. So it's a great field to specialize here in Nepal.
Thank you, Dr. Sarina. Dr. Ajit Thakur, anything that you would like to add over here? So you might want to unmute yourself.
Okay, sorry. It's an interesting and rewarding field. As Aditya sir told, someone came to you on toe and go on foot. That is very rewarding. So it's a rewarding field. And in a country like Nepal, you need a regular academic support in terms of reading materials and experts' opinion in formulating a treatment plan. And for this vision therapy, you need devotion in the field. And one thing is lacking, that record keeping. You need a good record keeping for your patient. That is another thing. And at last, you should have a good professional relationship with the ophthalmologist and others to have a good referral system. That's the main take of what I took of this talk.
Thank you so much, Dr. Ajit. It was a wonderful session, undoubtedly. Thank you to all our panelists here for joining me today on this panel discussion. Dr. Marc, Taub, Dr. Aditya Goyal, Dr. Ajit Thakur, Dr. Sarina Manandhar, and Dr. Celine. Thank you so much for joining me here today. Just a small note of special thanks to Dr. Marc here for allowing us to trouble you at this early hour of the morning and being with us here today, providing your valuable insights. We really appreciate it, and we love you for that. Thank you.
My pleasure. Thank you so much for everybody for being part of this. This is wonderful.
Thank you.
Thank you so much.
Thank you.
Thank you so much.
Have a wonderful night and have a good night's sleep.
Thank you so much. So on this note, we'd like to end this session here. This session will be on YouTube if any of our audience have missed any part of it. And again, thank you so much for joining us here. For our audience, please follow us on social media. And we will be coming up with more interactive programs, panel discussions, and e-learning sessions as well. Stay safe, stay healthy, and have a good day. Thank you.